It's a pleasure to present the different two instrument sets that we have, and one of them was discussed by Professor Aruz and Dr. Fazal. So this is a modern OR. This is the Vitom 3D that we discussed about, which we have outside. We're going to have the chance to see it together today, which is an exoscope 3D digital camera that can give you the chance to work on a monitor instead of binoculars or loops, and with a high magnification, a good clarity image, as well as the remote control, where you will be able, of course, it's covered with a sterile cover. And this we see also the tower, which is coming on a pendulum. And the good thing is that, the nice thing is that it's a thin arms that are holding the monitors that can move in different directions. And here also we have a telecast from the OR, whether endoscopic image or an outside camera, and to an external monitor or computer using internet, via internet. So Carl Storz, we didn't venture into stabilization, into fixation, into implants. We don't have that. We just have instruments, reusable instruments, autoclavable instruments for decompressions, whether stenosis or herniated disc. This is the spine tip, which has 3 scopes that can be used in upper and thoracic surgeries. Easy Go, which is particular, it's a dilation, and then it's a minimal invasive approach that is common for most of you. It can be used in both lumbar as well as in the cervical spine. So these are the main 2 sets that are being requested by surgeons and used. And then we have the endospine, which is an old system that we had. We still have it. And then we have the thoracoscopy, which is also an area that is not very developed. Still, it's underdeveloped, and only few surgeons are actually interested in that area. For example, I covered the whole MENA region, so all the East Mediterranean part, starting from Turkey, Iran, Pakistan, to the Middle East, to all of Africa. We have only 1 surgeon in Jordan, 1 surgeon in Morocco doing thoracoscopy, disc hernia on the thoracoscopy lateral approach. So it's still an underdeveloped field. I'm going to slip these slides, and I'm going to move directly to the first system, which is the Easy Go, targeting the lamina. It can be done under fluoroscopy. Some surgeons, they do it even without fluoroscopy because they can feel the lamina, because it's a short distance coming interlaminar. And this is an access that even open surgery, you know it. It's skin, fascia, muscle, lamina, ligamentum flavum, and then disc space. So with the first small dilator, and then we dilate over it, and then we dilate over it. This is the orange, which is 15 millimeter. So we can have the small trocar, or we can continue. The black, it's a dark color, and then the green, which is the 19, or we can continue to the black, which is the 23. In this case, the 19, the green, and then the cannula has been put, and then it will be fixed on an arm, on an autoclavable mechanical arm that we saw also the day before yesterday. So now the dilator will be removed. The cannula is in, fixed on an arm, 2 free hands. Now, this is the axis. Either a microscope can be put, or the Vitom 3D, the exoscope that I talked about and we're going to see today, can be placed for microscopic discectomy, microdiscectomy, or we have the telescope holder, and then we put the scope inside. And then we work through the cannula while looking at the monitor. We work through the cannula. Advantages of this system is, the name is Easy Go. Easy, it's easy to implement because the access is common to orthopedic and neurosurgeons already having experience in spine surgery. It's a common approach. Second, for big cases where the PELD cannot treat, like stenosis, some big stenosis cases, the Easy Go, you can see better, you have more space to work inside. That's another advantage for the system. This is how it looks. This is the instruments coming inside. This is how it is in live surgery. This is the cannula placed, and then 2 free hands, suction, and other instruments that get inside. I have many surgeons that they use both. They have the Easy Go for the interlaminar approach for some specific stenosis cases, and then they have the PELD for the transforaminal or the posterolateral approach that they use it for herniated discs or or even for stenosis, but which can be treated from the transforaminal or the posterolateral. And also, in addition to the interlaminar, also Professor Joachim Ortel, who visited Kenya in 2014, he also uses the same tubular as well to access the foramen. He just goes a little bit laterally, okay, to access the foramen to treat lateral, not far lateral, but mainly lateral disc hernias. It is possible.
German guy.
It's a German guy, yes.
We were together in Istanbul.
Yeah.
1 week before.
And he's a fun person to be with.
Yeah. He made an actually 2 laminars. I mean, he got into lamina, burr, and take the triangle out. Very interesting. With this, all migrated. You see the lamina, not take lamina, but just make a hole.
A hole just to enlarge a little bit to get an access to inside. Yeah.
That's also a good concept for stenosis, the easy go, whereby I can add pride compression. It's called over the top decompression. If we have lateral recess stenosis on the opposite side, contralateral. So you can actually, with the table, you can turn the patient and you fix the dilator and also turn this tube. Also turn the tube and you drill the spinous process, base of the spinous process, until you can see the nerve root on the opposite side. Right?
There's a surgeon in the UK, actually in the UK, he uses the easy go for big tumors on the brain. Where they look, yes. Believe it or not. And in the UK, where you know that healthcare is very well controlled off-label, but he uses it. But he's from Lebanese origin. So this is the old generation where it was a 45 degrees angle, the telescope. Sometimes the camera, when it's connected here, it used to come in the way of the surgeon. So to have it like more as a bayonet shape, so now it's 90-degree curve, the new generation where the camera is connected here, so it doesn't interfere with the instruments while working. So this is the modification that has been done. So this is how it looks. This is the camera. It's oblique, 45 degrees, while here it's 90 degrees. So you have free space while working. The second advantage of the EasyGo 2 over the 1 is a bigger space for working, which was taken by the scope before. So now we have a more enlarged, a wider window to work from with the EasyGo 2 system. Also, we do have a silver book on EasyGo by Professor Ortel that details very well the different indication that can be done, different pathologies that can be treated. A DVD as well is available that also has several surgeries being done, stenosis, hernias on multiple levels as well. We'll be more than happy to share with you as well. So this is the technique. It's almost 1 finger, 1 to 1.5 centimeter from midline, the classical approach that you know. Moving into percutaneous endoscopic discectomy, or known as PELD, percutaneous endoscopic lumbar discectomy. So I'm not going to go into technical details because we heard already, and we're going to get another nice talk by Dr. Ouz. So just to talk about the instrument side. The spine tip stands for transforaminal, interlaminar, posterolateral. Transforaminal blue, interlaminar is the red, and posterolateral is the green. Optimal is to have the 3 scopes. Sometimes it's not possible. Okay, sometimes for budget constraints, like for example, Dr. Fazal, Dr. Kasmani, they invested themselves in the red scope only. So the red scope is a 25 degree, it's 18 centimeter working length with a 3.6 centimeter, 3.6 millimeter of working channel inside of the scope. While the blue scope is 25.5 and 25 degree also angulation with the same diameter, also 3.6. So this and this are very similar, but the only difference is the length. And this is what Dr. Ouz showed in the fat patient. He said 170 kilograms. This is the scope that he used that can, for large patient, it can be useful. Now for thin patient, even this scope, because there was a question by Dr. Kasmani to Dr. Ouz, this scope can be used also transforaminal for normal patients. Okay. And then there's the green, which is the posterolateral. it's 15 degrees angles. And why it's 15 degrees angle? And this is what Dr. Lubers say, and I would like to know also from Dr. Who's about your experience. He says that going with the green posterolateral, this is the true posterolateral scope and not the red. Because red is 25 degrees, this is 15 degrees. With the green, after finishing the inside out, he goes out in to see the nerve roots. And with the 15 degrees for him, it's much easier to visualize the nerve roots because he wants to see the nerve roots. He wants to make sure that the nerve root is completely decompressed. So this is according to Dr. Lubers. What do you think, Dr. Rose?
And one thing is that the other important thing is with this Luberstick, I'm using also Luberstick. You use the straight, round, working cannula.
The straight working cannula. Yeah.
If you use 25 degrees, the vision can be obscure because it's not up, open up. Yeah, you understand me? You have to look straight.
Dr. Wuz is saying this is an oblique cannula. You see that? This is the working cannula. Now, for this case, you're saying that for the posterolateral, you use the closed cannula?
Yes.
So with the closed cannula at 25 degrees scope, it might obscure the vision. You will not see because you have the tip of the cannula that will be hiding some of the image, right?
Yeah. And also, they show that.
Sorry, please.
And also, one more problem is, if you use the oblique one, when doing foraminoscopy for extraforaminal discs, we use foraminoscopy, which means you enter the foramen and see exiting nerve root. If you use this one, it's dangerous. The nerve can enter this blunt area, this oblique area. But if you use a blunt one, straight one, nerve cannot enter where you're working.
So it's hidden.
Yeah.
So, okay.
Yeah.
So always
that's the reason.
where you're working is
you have to look straight.
Okay. So that's why the 15 degree
Yes.
would be useful. Okay, it's good to know. Good to know. So this is the transforaminal, which is the long scope, but also the red scope can be used from the same for the same approach for thin patients. This is the interlaminar approach, and this is the posterolateral approach. Already this has been discussed: MRI, placement, dilator, working cannula, and then MRI, and then scope over it, and this is the end results. This is the Gore technique, which is Dr. Gore is always convinced with the posterolateral only. Okay, he doesn't go transforaminal, he doesn't go interlaminar. Some of the students of Dr. Gore, they use sometimes the interlaminar approach, especially for the L5S1. But Dr. Gore, for all of his cases, he goes posterolateral and always inside out. Even when the fragment is medial, he goes inside out and he catches it from inside. He has a philosophy. I'm sure that he explained it to you. The fragment out, he takes it out when he sees the bleeding going out of the disc, because inside of the disc is their blood. So he knows that the fragment has been removed, a total fragmentectomy has been removed. And also what Dr. Fazal was mentioned about the red at the end of the fragment, that means that he had enough pieces. So it's a different school. It's a different school. I mean, if it works for him, that's great. If it works for Dr. Lubers or Dr. Ooz or any of you, it's also fine. So these are the pumps. We have the irrigation pump, which is reasonable in price to do a good irrigation during spine surgery. And then we have the dual pump, which is irrigation and suction. So you can have both irrigation and suction on the same scope. And same from the PLD, we have the silver book from Dr. Lubers, from Dr. Thomas Lubers, who explains the 3 different techniques, the interlaminar, posterolateral, and transforaminal, with the surgical videos also that is nice on each of the approaches that details the techniques. So thoracoscopy, just one slide to mention that we have this system. It's an interesting area. And if you ever see the surgeons operating, the experienced surgeon operating, this really nice procedure can be done. Tumor removal, fragments removal, herniated disc, stenosis. It's actually interesting, but these are long procedures. Surgery, blood transfusion is needed. Sometimes general surgeon is with the orthopedic or the neurosurgeon to do the operation. And yeah. So thank you very much. Any questions? No. We move to Dr. Ouz.